Hi, everybody. We're here virtually with Casey Vandale and Catherine Considine. They're therapists at Mass General. They work with Dr. Bassem El Hassan, who we all know and love. And we were really hoping that they would join us at our tendon transfer course, but we neglected to tell them about the food and wine pairing event. And they just unfortunately have other obligations. Maybe next time they'll be with us. So welcome, Casey.
Thank you.
Thank you.
Welcome, Catherine.
Thank you.
So we were just starting to talk before we started recording about patients that are good candidates for tendon transfers. And they asked me a question about whether I do these. And I said, I had done a handful of them before Bassem came. And, ever since he came, I feel like I should at least inform people that, he's an hour north, so that if they'd like their surgery done locally here in the Fall River area, I'm happy to do it. But, it didn't, at least it doesn't make sense to me to tell people, oh yeah, let's do this, and then not know that like the guy who invented the procedures, driving this. So hopefully one of my patients that is having this procedure the first week of November, so in a couple of weeks, is going to be able to join us. Hopefully the people that are watching this recording on Saturday already met him this morning, which would be awesome. And I've also had a handful of people that I've sent up to Bassem, and he's done a lower trap on. Interestingly, one of the people ended up also needing a latissimus transfer anteriorly. And it was funny, I was talking to him and he said, yeah, I don't know what he did in the front, but it feels great. It feels great. So I think one of the things that we'll talk about, and this is why Casey and Catherine are here to help us, is trying to get like a sort of a three-dimensional picture of what happens from everybody's perspective, right? Because I think everybody is going to have a hard time seeing it from anybody else's perspective, like surgeons that are indicating these people for these procedures and then potentially doing the procedures have a perspective. The patients who just want to get better have their perspective. Therapists who are taking care of these patients preoperatively, postoperatively have their own perspective. And in order for us to do the best job possible, the goal of the course and the goal of having these discussions and conversations is to help everybody kind of see everybody else's perspective, so that when we're making a decision, it's not just saying, I'm a surgeon and this is what I do, or like I'm a therapist and this is my protocol. Everybody understanding everybody else sort of helps things sort of move in the right direction, making the best decisions possible, giving people the best results possible. So with that for an introduction, I think we've emailed back and forth about a couple questions that I was going to ask you, but I don't know if you guys want to start off with, just sort of like a little blurb intro of yourselves, your practice, what kind of patients you're seeing, and then how that relates to tendon transfers, and we'll go from there.
Sure. I guess I'll start. So I'm Casey, and I have actually worked up with the shoulder surgeons for probably about 15 years with a variety of different doctors over time. I see, in terms of my caseload, is orthopedics, but I do have a specialty in shoulders. And when Dr. Hassan came to Boston 2 years ago, we wanted to make sure we could welcome him and help support his patients when he got to Boston. So Catherine has also been up, not to speak for you, but has also been up in shoulder clinic for a couple of years, 5 or so.
Time flies when you're having fun, right?
It's funny, you go by okay, was I married then? Did I have a kid then? Type of those things.
So interestingly, we mentioned this before, but I was a shoulder fellow at MGH in 2012 and 2013. Casey was already there. Catherine was not there yet. Casey had a different last name, and it took us a little bit to sort of put the pieces together to figure out that, oh my God, we actually know each other already.
So it's in the way that our shoulder clinic works up in here at MGH is the doctor is down the hall seeing patients, and we have our own little PT room on the side. And I've actually, or both of us have realized how important that is for patient care. It's so great when you got a patient that you're concerned about to put them right in front of the doctor and say, let's figure this out together. I was actually up this morning with Dr. Elson, and Catherine's going this afternoon, and it's just really, it's a really nice opportunity to kind of work out issues together and work as a team. And I think one of the things that we'll talk about today is it's really important to have good communication with the surgeon. And if you have any questions or concerns, talk to the surgeon or the PA or the team to make sure that you're progressing the way that it should be going.
Yeah, no, totally. And I think all the therapists that are attending on Saturday have my cell phone number. Some of us actually have like Tiger Text, which is like this secure, two-way texting where like, they can send me a message anytime, be like, hey, like so-and-so was just here and they said that they have been wearing their sling, like, like, stuff like that, where it's, not just Gestapo tactics to like snoop on the patients, but also like, if somebody's doing like extra good and like, we want to progress them maybe a little bit more quickly, like, hey, like I got a text like earlier this week, like you sent so-and-so with a scapular fracture, you wanted them to do pool therapy and like just gentle passive range of motion. He comes in with 160 degrees of active fore elevation. Is it okay if we progress along? Like, sure. Like, I didn't think he'd be able to like regain active motion with a scapular fracture 2 weeks out from his injury, but if he can do it, like, all right, like he's going to do it anyway, right? You might as well work with him in his reality. So I completely agree. I think that two-way communication benefits everybody. Like it's good for the surgeons, it's good for the therapists, good for the patients, good for everyone. So how much of your practice is rotator cuffs versus total shoulders versus tendon transfers? Like if you can, rough percentages.
I guess we are seeing more lower trap tendon transfers more so lately, but we still probably are seeing still more rotator cuff repairs than lower trap tendon transfers. We also do see a lot of total shoulders and reverse total shoulder replacements. So I like a good mix.
It's hard to say too, because the Dr. Alessandro now and Dr. Warner, who we were working with previously, he now works in the Waltham office, so we're not working as closely as we were in the past. But they are often doing, the revisions of like a revision rotator cuff repair, the reverses, lower trap transfers, any muscle transfer. So we happen to see quite more than most people because of that connection.
Right.
So,
right.
I think in terms of caseload, I think probably like 80% of my caseload is probably shoulders, and it's probably evenly split between all those things and fractures.
Yeah. And one of the things that I wanted us to like be very like sort of clear on is, the similarities and differences between a rotator cuff, which is a soft tissue procedure in the shoulder that is, for the most part done arthroscopically, and the tendon transfers, which are soft tissue procedures around the shoulder. And I think one of the assumptions that we don't want to make is that, just because we're indicating people for a similar thing and we're hoping for a similar outcome, that the rehab is going to be the same, right? Like that trajectory on how to get from point A to point B might be completely different. And I think you guys are the perfect people to teach us about that. And I had sent you guys my sort of like breakdown of how, we stage people for rotator cuff recovery. Is it similar? Like, is that what I sent you guys similar to what you guys seem to do and see?
Yes. So let me step back too. So prior to Dr. Ellison coming, we've worked with Dr. Warner for years, which is how you and I met. Right. And your protocol is almost pretty much verbatim what Dr. Warner's protocol is for a rotator cuff.
Right.
And so before Dr. Ellison came, we were starting to see some of these lower trap transfers coming from Dr. Warner. And the way I kind of thought about them when I was first starting to see these patients, and also pulling in colleagues and helping them think about their patients, is tell them in terms of the rehab is very similar to a rotator cuff repair, because for the reasons you just explained, but it's extremely important to make sure that you're protecting the length and tension of the procedure. So you really have to protect the procedure is what we usually say. So Dr. Ellison's protocol is a little bit more conservative than Dr. Warner's. I'll get there in a minute. But the biggest thing between a rotator cuff and a lower trap transfer, if anyone to take home, is you don't want to overstretch it, overload it too early. So we do internal, I was gonna say, so no internal rotation. No, don't encourage person to stretch behind their back. Don't stretch them in the clinic internal rotation, because that specific stretch will put too much, will reduce the tension from the actual transfer.
For how long?
Honestly, sometimes never. If someone cannot reach to their sacrum, like if someone can't reach to tuck their shirt in, maybe you do a little bit of stretching to help with that. Like if there's a functional problem months down the road, very gentle stretching, internal rotation is okay.
I think Dr. Ellison allows them to begin to reach behind their back around 16 weeks, but we wouldn't stretch them into internal rotation.
Okay.
As far as like in the doing
so say that what starts at 16 weeks?
Allowing the patient to begin to reach behind the back.
Okay. Because
Allow
that's something that's a limitation of reverse replacements, but that's more of like a sort of a mechanical limitation, not a sort of precautionary limitation. Like I think historically, when we were worried about dislocations, I think, people would be like, oh no, don't reach back there, you're going to dislocate. But I think we've learned that, it's not so much the dislocation risk, it's just a functional anatomical change that like people with a reverse are just not usually, some people are able to get here, but not usually able to get past here.
Right, and if you do it too soon after this surgery, you're overstretching the tendon transfer, and then you can't engage the muscle the same way. So you can effectively destroy the procedure.
So that's really important to know, because I think I tell people that before the reverse, but I didn't think to tell people that before a lower trap transfer. So that's good, and that that patient that we're planning on doing the first week of November, I think it's important for him to know that and to hear that, and that's not necessarily a limitation of the procedure or a precaution or anything like that. It's, hey, listen, everything's a trade-off. Like you cannot do this right now. You cannot do this right now. You cannot do this right now very easily. If you want to be able to do that, you're going to have to give up a little bit of motion in the other direction, which, I think is part of the, what I will call the uninformed consent process, but at least our best attempt at an informed consent.
I think too that people eventually get it, but it's the you can destroy the procedure if you do it too early. So that's what we always really focus on telling patients, but actually more of the therapists that we worked that haven't seen these as often is we really stress that, because that's when we've seen them fail. I've only seen one fail actually. And we were wondering if his attention was off because he just couldn't get the lower trap to activate. So yeah, that's the biggest thing, because as therapists, we're trained to really protect those tendons with a rotator cuff repair. So it's the same philosophy, but there's more risk to this, because if we overstretch the transfer, there's what's next. They could revise it, but it's not going to be as good as the first time. It's not like you have a rotator cuff repair, you fail, and you got a muscle transfer to move on to.
Right.
So people get really freaked out by that.
Okay, so let's talk through this. So we start time zero. We fix the tendon. We transfer the tendon. Fine. Immobilization for the rotator cuff repair, I think, it's kind of a dealer's choice. Some people like a simple sling, some people like an abduction sling. I don't think personally it really matters. I give people an abduction sling, not because I want them to necessarily be abducted, but psychologically they're more likely to wear it because it looks more expensive and it looks fancier than a simple sling. I don't think, like me personally, I don't think that the position here versus the position here is going to make that huge of a difference, mostly because like they're going to take it off to shower, they're going to take it off to do things. So their arm is going to come to their side. They're going to, get underneath their arm like this. So I don't think the abduction position for a rotator cuff repair is a make it or break it kind of thing. But that pillow and like the black velvet look of it, like it makes them feel like, okay, like I need to take this seriously, so they're more likely to wear it. I've had people for whatever reason that I've chosen to do a simple sling on because I wanted to get more internal rotation for them, and they just don't wear it. They just don't take it seriously, which is annoying because sometimes, like, from a cost standpoint and from like like practically speaking, like if you, as long as you wear the sling and as long as you keep your arm next to your body, your rotator cuff is going to be fine. I've been told by Dr. Al Hassan that he prefers the SCOE.
He's in the mostly in the gunslinger.
Okay.
And he's mostly been having patients get fitted at their pre-op appointments. So I think that's helped a little bit with compliance because they've been able to either get the right fit for it before surgery, and also the idea of the gunslinger is to help to keep them in the right length and tension of the tendon for healing.
Okay, so this is like if you Google gunslinger, this is what comes up. Is that kind of what it looks like?
Exactly.
So how different would that be from this external rotation brace? And how different would that be from a Bragg hyperabduction brace? So I've used this before where like I really want people to have a lot of abduction.
I don't think you need a little bit more external rotation because you're trying to, again, prevent relative internal rotation. So that's where the gunslinger really holds them out in kind of more position where it's harder to achieve. So you have relative external rotation compared to internal rotation. The other kind of nice.
So what about this one? Like, would that be?
That would
no,
it's not the right tension.
Okay.
Because having that correct tension and having healing in that right position is what's crucial for having this be successful.
So really, this is what we're looking for.
Yep. And I think that when people come get fitted first, they're understanding what they're going to be dealing with for the next, usually 8 weeks, sometimes 6 weeks. And I think that actually helps people realize, oh, this is a big deal, and they're actually take it more seriously. And the other thing Catherine and I were talking about, a lot of these patients have had multiple surgeries, long history of shoulder problems, so they know they're at their last resort. And if
they know that it's high stakes, right?
Yeah. So I think that because we too have seen issues with the compliance, a lot with the rotator cuff repairs, and people walk out of the hospital and have a sling on, didn't know anything about it before they put it on. It doesn't feel like very much because it's just a soft brace. And when you come out of this thing, you're like, oh, okay.
It is the real deal. And I know sometimes he puts people in a spica, which I'm like, like I guess if you're Bassem Al Hassan, like you talk to people and like, oh, you're like, they're like, sure, yeah, whatever you say. I'm not going to be able to convince anybody to do that. There's no way.
You will.
But they're going to read it on me that like I feel bad. Be like, yeah, so I think what we kind of maybe should do is like put you in like this cast that goes from like here and like holds your arm like this, and then you can't move at all, and you're always waving to people. Like,
but it's only for 8 weeks. It's only for 8 weeks. It'll go by so fast.
That's like saying, oh, surgical training, it's only 6 years. Like, I don't understand.
Exactly.
Big deal. Like,
for PTs.
Oh, yeah. It's no big deal. So I think understanding that like time zero, and just talk me through. So like if they're here, right, like in their brace, they're taking off their brace to shower. Where are they putting their arm? Like, did they put it?
They usually say that they're just, can help to support their arm with their non-operative arm into a little bit of external rotation, or if they can just like keep the arm by their side, always supporting it, which is, not. It's a tough ask.
This position right here, that's like in order for them to be able to keep their hand in this position, they're firing their lower trap. They have to be. because they can't do it right now pre-op.
Right. So it's
That to me, I'm like, I'm not like, if I was bold enough, which I'm not, to put people into a spica, I'd be like, okay, I feel comfortable. But if I'm not, right, which I am not, and I'm gonna put them in a brace, I'm like, we're fooling ourselves, right? Like, oh yeah, you're gonna do this brace, blah, blah, blah. And then, like, you know, the second they're out of the brace for 5 minutes, we're already stressing the repair. So I don't know, like, for me, I don't wanna, I have all the therapists here are gonna laugh. Like, I'm gonna be like, I have a tendency to worry. Like, yeah, obviously you're a crazy person. But like, what do we do with that word? Like, what can we do about it? Do we just say, fine, cost of doing business, like 10 minutes a day isn't gonna make a failure? Or is there something that we can do that actually protects the repair when they're out of the brace?
I think the biggest thing is stressing you stay in the brace. Actually saw an old patient who just had this procedure done. She's not ready to start PT yet. And I said, how are you? Do you mind getting that? Sorry, we're in a room that's a big gate. I said, how are you getting dressed? And she said, just pull it right over. So they're so concerned about the position, like keeping the brace on. I think just as much as we can support, like, you need to be in there all the time. When you are out of the brace for showering or bathing, you got to make sure that arm is not doing any work to hold it up, and do it for 8 weeks.
So, okay, so the brace is going to be out here, gunslinger, external rotation, abduction, no abduction brace, no external rotation brace, no breg. We really want the gunslinger with the maximal external rotation. I said gunslinger, right? Like, I didn't like,
yes,
because I have a tendency to say the same thing twice. Okay, so gunslinger out here. Wear the brace as much as you can. Wear the brace as much as you can.
all the time. Don't take it off.
Don't even question. Do not take it off.
No shoulder
Really?
motion.
They don't take it off.
Take it off
Sponge
to shower.
baths.
Yes.
Sponge baths. I don't-
Okay,
If
but
you
like,
want this to work.
like showering is like a real thing, and like,
I know.
they're not gonna
Yes.
not shower for 8 weeks.
No, of course they're not. But if strong as you can be about this should not be coming off, there's no question out there all the time. You have to take it off to shower. You have to take it off to dress. Once they
24/7, 8 weeks. Got it.
Yeah, and once they try it in the office, they're gonna know how hard it is to exist like that. So they'll be thinking about how they're gonna wear cardigans and button-up shirts, like ways that they can get around that brace. That's another reason why it's so nice to have. I mean, it's Dr. El-Hassan likes to fit people ahead of time, but we like it because people understand what they actually have to deal with.
Right, and I think I've mentioned this a couple times. I think understanding the problem 3-dimensionally, understanding everybody's perspective, what everybody wants, what everybody needs. I just had a guy come in who's 3 months out from a supra-infra subscap repair, which, I lay a lot of crepe. Like, I might not be able to fix it. If I fix it, it might not stay. If it stays, it might not heal. If it heals, it might not function. Like, there's all sorts of layers. Like, this is high stakes and it may or may not work. So this guy's 3 months from basically everything from the teres all the way up around down to the front of the subscap. And at 3 months, he's got full motion, he's got full external rotation, full internal rotation. And I'm like, I'm going to tell you something you're not going to like. You're doing too well. And I said, like, there's things that you want and there's things that I want. And ultimately, I want this tendon to heal and for you to have a good result in a year. And you want to get better quickly. And let's try to give both of us most of what we want. Right now, you're getting more of what you want, and I'm worried about not getting what I want. So for me to be happy in the long term, you need to slow down a little bit and recognize, just because you feel so good doesn't mean you can do whatever you want. And I think understanding what people want and understanding what their motivations are helps us to tell them when they can go and just kind of do whatever you want, versus I need you to not be happy short term so that you can be happy long term. So I think that's a great point about getting them fitted with the brace ahead of time. Now, for a rotator cuff, it's 6 weeks in a sling doing nothing, 6 more weeks, no pushing, no pulling, no lifting. It sounds like with the tendon transfer, it's 8 weeks in the sling. Is that right?
Yeah,
Yeah, go ahead.
yeah, I think, yeah, 8 weeks, sometimes 6 weeks, but
Let's
mostly
just
8
call it,
weeks.
like, I'm not
Yeah,
gonna
8
push the envelope. Like, if I'm
Yeah.
doing it, it's 8 weeks, right?
Yeah.
So, for a cuff, I will start people either in the pool or in the office with a therapist that I know, somebody that they know my first name, I know their first name, they have my cell phone, like, they can walk over from like the clinic next door to see me, or they can, send me a message any day, anytime to let me know what's going on. So either in the pool preferably, or in the office, just passive motion at 2, sometimes 3 weeks. Do you guys start that, or does that start later with the tendon transfer?
So we don't start any physical therapy until the 8-week mark. So we're not seeing them at all. So they're just in the sling for the entire 8 weeks. They can do wrist and hand and elbow motion as long as they're not doing any shoulder motion at all. And then, so we're really not meeting them until the 8-week mark, when either once they've been discharged from the sling at a post-op visit, or they're just coming out of the sling, either with us, or so either we're meeting them basically after they've come out of the sling.
So they're simultaneously working on passive motion with you and active assisted motion on their own once they come out of the sling?
Once they come out of the sling, they're starting to move, so active assisted, active motion, and we're doing some passive motion, but we're really not stretching. So it's more kind of guiding them to move in functional ranges, and really emphasizing no overstretching.
Okay.
So, and that's one big thing that Dr. Ellison has really kind of pressed since he's been here. Again, he really wants people to be successful and doesn't want to have that extra tension, or extra loading and stretching. And it was a weird thing for us to get to our heads around. And when we talked to other therapists in the community, that's also been like, why can't you stretch them? And, we try to, how we usually handle it is we try to get them to move as functionally as they can, sliding their arm on the table, going up the wall when they're ready. But if someone's really stuck and having a hard time, that's when we usually go back to Dr. Ellison or the referring surgeon and say, can we just do a little gentle stretching? I really know that we can't overdo it, but this person's not getting it, and we need to find another way to get there. So honestly, I've been surprised how few times that has happened.
We're not really, like, for most of our patients after lower transfer, we're not manually stretching them. We're just guiding them in self-stretching or self-active assisted motion, stopping before the point of stretching and working on active motion, and they're doing really well with it.
So something like a doorway stretch is not something no, but a rotator cuff repair would, or wouldn't also?
If they need it, doorway stretches are a little bit too aggressive for me. There's other ways to work on external rotation. Maybe at the very end, if you're having a hard time with external rotation above 90, maybe I would do a doorway stretch. But I would avoid anything that's really aggressive stretching through the joint, even for rotator cuff, until they're.
Sorry, go ahead.
No, even until like they're far out if they're having a hard time. But early on, I wouldn't do that aggressive stretching.
So I think we need a whole session on just this. Right. And we'll invite you guys out. If you want to come down, we'll feed you dinner. If you want to do via Zoom, we'll send you like a little box dinner from like a local establishment.
No, we don't need dinner. We don't need anything. We just need more than 2 weeks.
I'm not going to throw anybody under the bus.
I didn't mean to throw anyone under the bus. Sorry. We've known each other for a long time. We'll go way back.
So
no, I'm serious. Just we can definitely make a time to come down. We'd be happy to do
so
that.
I think we need to do a whole session on this, because I think as surgeons we're so focused on how to get the tendon to heal, that like I truly and honestly I don't care how people get their motion back. And we just had the Shoulder Society meeting this past weekend. We all know the study by Brad Parsons out of Mount Sinai from 15, maybe even 20 years ago, that said like people with stiffness early on, people that are stiff at 3 months have a higher healing rate and equal, like, same range of motion at 1 year. So early stiffness is actually protective, and it actually indicates a better healing. So, how we get people to regain their motion, and I totally agree that, like, it's more enjoyable for the patient not to be stiff early on. Like, there's a difference between the patient that, it's not quite symmetric, right, between that side, the operative side, and the non-operative side at 3 months, and the patient that's, like, at 3 months still, like, struggling to get past 90. Like, that's no fun. So I think trying to avoid those, like, really, really stiff people at 3 months, I think is something that we need to talk about on an extended, basis in terms of having, like, a separate thing for that. And I think for now, the final question that I would have is, what can you tell people to expect? Like, because you see these people pre-op and you see them post-op. What can you tell them? And this is somebody with an intact subscap, complete external rotation deficiency, no supra, no infra, like no external rotation lag, compensation, but, like, really, like, difficulty and fatigue with overhead elevation. What do they get out of a lower trapezius, like, in terms of their function, like, once they're fully recovered, and how long does it take them to get there?
I think it's a long road. So it can really be, more than 6 months before they're really allowed to get back towards full activity. And it can be really like a year to kind of get to optimal full recovery. And so someone may be able to do those, like, more challenging activities, but it may not be like the same, like doing power activities or things like that, like heavier, like worked with a construction worker, and so he's maybe, like, rethinking doing something that requires this heavy using this heavy iron bar way overhead. So but I think people they're successful with challenging activities, but it takes a long time. It does take a long time to get there.
And I think to go along with what you're saying before is that these patients are realizing that they're kind of at a last resort. So I think there is a lot of rethinking of what they need to have done, or like what they need to do after the procedure. I mean, people go back to golf, but it's one of those things. There's a risk to it. So yes, you can pretty much get back to what you want to do, but know that if you injure this arm again, the outcome might not be as desirable.
So this is something that I suggested to Bassem as, like, a framework. And he said this might hold some merit, where people that are profoundly weak and you do a tendon transfer, they'll get some external rotation, but not what would be considered like a functional, like, happy usable arm, but at least they're able to, position their hand in space and be able to get, like, light activities out of their external rotation. People that already have that, right? People that are able to at least, like, fake it till they make it and, get through the day, but feel weak. If you do a lower trap transfer on those people, they have, pretty full normal function, like, compared to where they were. Are they going to be as strong as they were when they were 25? No. Are they going to be able to lift 50 pounds above their head? No, but they'll still be better off than where they were. So is that, like, a reasonable thing where, like, you can take somebody from one category and get it to the next, but you're not going to be able to, like, jump to 2 categories ahead? Is that, like, a reasonable expectation?
Perhaps. I think I just think about it differently.
Okay.
I mean, I think any patient that comes in the office, our goal is to make them be successful as possible. And if they were unable to do this before surgery, the goal would be hopefully we can get it after surgery.
Okay.
Not necessarily a lower trap transfer, but I've had patients in the past who've had, like, a bank heart say, "Can I do push-ups when I'm done therapy? I could never do them before." And I was like, well, probably not then. But, like, I think so. So I think that there's some merit to what you have before, what your outcome is going to be at the end. I think a lot of PTs take the perspective of, okay, we are going to push to get as much as we can get as possible. And if sometimes we're surprised and other muscles sort of compensate a little bit more, we get a little extra, now that the shoulders functioning in a different way that it hasn't been able to do for the last 5 years. So I think we might be expecting and bracing for maybe a poor outcome, but I think it's always worth kind of moving forward until you hit that point where you're not making any more gains.
Okay. But do you think that, so what I tell people is if they had a rotator cuff tear, right, and we fixed it, that once that tendon heals, the sky's the limit, right? Like there's no like limitation in how strong they can get, right? Like I don't think any of us is as strong as we could be, right? Like if we wanted to like, do X, we would do X. Like we just need to put the work in to get that strong. Somebody who has a torn rotator cuff, hypothetically that could be the case, but like, that the analogy that I give people is if you're racing against NASCAR, souped up cars, you show up with a Honda Civic, there's only so much that you can, get that Honda Civic to be competitive against the NASCARs, right? So with a torn rotator cuff, yeah, there's things that you can do to optimize your strength, but there's going to be a ceiling, and there's only so far that you're going to be able to strengthen. So would you say that with a successful tendon transfer, that these people's capacities to get stronger is equal to a rotator cuff repair, like an intact cuff? Or is there going to be a gap where they're going to hit a ceiling similar to somebody with a chronic cuff tear?
I actually feel like sometimes they do better.
Really?
Because if you got a torn, frayed rotator cuff and you sew it back together, hopefully it heals, but there might be other portions of that, like the posterior cuff, that's still a little bit frayed. And so by taking the posterior cuff out of it and just doing lower trap, people have sometimes significantly better function afterwards.
All right. Well, I hope that's the case, and I hope that my patient who's hanging out with us is still here, and got that super boost of confidence that this is going to be something that is going to be successful and long lasting for him, because he's in his 40s, and that's a tough place to be, to have no external rotation in your 40s. Like to be able to restore that, I think is really a significant, substantial improvement in quality of life. Cool. So we went through the brace, the positioning in the brace. Never take it off. If you take it off the shower, get it back as soon as possible, and try to support the other arm. Support it with the other arm and keep it in that position as much as you can. Or if somebody can help you, that would be even better. Nothing happens for the first 8 weeks. So there's no passive motion, there's no pull, there's nothing for 8 weeks. Keeping that tension and keeping it out there. Once they start, it's not so much about, pushing on the arm to get passive motion back. Certainly not anything internal rotation. We avoid that at all costs.
Yes.
We let people do active and active assisted range of motion to get to within their functional range of motion. And most of the time that translates into a meaningful improvement over time. Once they have their full motion, that's symmetric with the other side, somewhere, it seems like you guys are talking about 4 months, they can start resistance. Is that right?
Yes. Yep. Usually about 16 weeks. Yep.
Yeah. 16 and 40 minutes. That time frame. And, similar to a big cuff repair, 6 months to a year, before we say, oh, we're happy, we're not happy. Like, I love when people tell me like, I just thought I'd be further along. I'm like, I told you it was going to be a year. They're like, yeah, I know. But, I'm like, you're at 3 months. They're like, yeah, I know. But I'm like, listen, like you're thinking it's already been 3 months, and I'm thinking it's only been 3 months. So I think for a lower trap, it seems like 4 months is 3 months, and 8 months is 6 months. Like it's like a little bit of a longer time scale. All right. Any other pearls of wisdom, guys? Any advice for me? Any advice for whoever gets stuck with the patients that I'm going to be sending their way?
Just slow, light resistance to start with for strengthening, and before progressing, making sure that someone's not compensating, and that they have good mechanics with their motion before progressing, and also focusing on hip strengthening and core strengthening
Yes.
is also big with these patients.
Yeah.
And have,
That'll be another thing that I think, we'll talk about. I think getting passive motion back is huge. Getting the whole kinetic chain involved and realizing there's more to it than just being able to pick up your arm. Actually, the current president of this European Shoulder Society just presented a case where a patient, when they're sitting down, has an external rotation lag and external rotation weakness after her reverse. If she stands up, she gains external rotation. And he said, I have no idea why this is. I'm like, I do. The physical therapist taught me that the core, can stabilize the scapula. The scapula can position the glenohumeral joint. And if the core stabilizes the scapula and the scapula positions the glenohumeral joint, they can regain a mechanical advantage to be able to externally rotate when they can't. I was like, that's the answer to that question.
exactly.
That's the therapist, like they'll tell you. But yeah, like he presented that case, and I think that I mean the point that you're making, I think, is huge, especially if we're doing the lower track transfer. It's going to be that much more important to make sure that we engage the core and the paraspinal muscles. And
don't have good communication with the team, the whole team. And if you have a question, ask it. Don't try to figure it out. This could be the end for a patient. So
I drive Bassem crazy. He's like, are you
the therapist?
Are you like a trained surgeon? Like, why do you ask so many questions? I'm like, because it's hard. It's confusing. Like, we want to do a good job. Like, you got to ask. So yeah, so hopefully Bassem's listening to this and be like, Casey and Catherine, they told me to ask, like, like, I know, but like, just do it. It's going to be fine. You're a good surgeon. You can figure it out. I'm like, no, but I want you to tell me. All right, guys. Anything else?
No, well, thanks for including us. And seriously, we'd love to come chat some more. So just let us know how we can be helpful.
Fantastic. Looking forward to the next time.
All right. Bye. Nice to see you. Bye.